This presentation is the pathology of abnormal uterine bleeding as it pertains to the uterus. Dysfunctional uterine bleeding is a clinical term for uterine bleeding that lacks an underlying organic, that is, structural abnormality. Although well-defined pathologic lesions can obviously cause abnormal uterine bleeding, such as chronic endometritis, endometrial polyps, submucosal leiomyomas, or endometrial neoplasms, the most common cause is from hormonal disturbances. Now, as you've learned in other disciplines in this course, the normal cycle of endometrial proliferation, differentiation, and shedding requires a synchronous and quantitative coordination between pituitary and ovarian hormones. Any disturbance of this finely tuned system may result in dysfunctional uterine bleeding. Anovulatory cycles are one of the most common causes of abnormal uterine bleeding. When associated with menopause, anovulation is typically due to the declining functional capacity of the ovary. In younger patients, disorders in the hypothalamic pituitary system may contribute to anovulatory bleeding. Whatever the ultimate cause, dysregulation of the balance between estrogens and progestins result in alterations in endometrial vascular homeostasis and leads to irregular bleeding. Progesterone is required for successful implantation and maintenance of pregnancy. Therefore, disorders related to impaired progesterone production or action are likely to affect pregnancy success. A defect in corpus luteum function, that is a luteal phase defect, has been hypothesized to be a potential cause of impaired progesterone production and resultant infertility or pregnancy failure. A luteal out-of-phase event occurs when there is early luteal phase recruitment of a follicle that then matures precociously, resulting in high levels of circulating estradiol and associated increased menstrual volume. Thus, inadequate luteal phase may also cause women to experience some combination of irregularity of bleeding and a variable volume of bleeding. Endometrial changes may also become dysregulated from the use of oral contraceptives. A common response pattern is a discordant appearance between glands and stroma, usually with inactive glands, amidst the stroma showing large cells with abundant cytoplasm reminiscent of the decidual changes of pregnancy. It can also result in a mixed pattern endometrium, that is, an endometrium that shows both secretory and proliferative pattern glands. When oral contraceptive therapy is discontinued, the endometrium usually reverts to normal. Persistent estrogenic stimulation leads to formation of cystically dilated endometrial glands with an irregular distribution, as seen in the top panel. Stromal breakdown may be patchy due to ischemia from focal fibrin thrombi and spiral arterioles. In the absence of persistent estrogen elevation, two patterns may be seen depending on the duration of estrogen exposure. With longer exposure, the cystically dilated glands are not prominent, but other features of anovulation, including tubal metaplasia, indicated by the red line showing small cilia projecting from the cells into the lumen. Patchy breakdown and surface repair are present. When there is an abrupt loss of estrogen, such as a defect in follicular growth, so-called failed follicle, uniform tubular glands with diffuse stromal breakdown, called stromal collapse, are seen. Notice in this image how the stroma appears condensed and hypercellular in comparison to normal endometrium. Endometrial polyps are relatively common, being present in up to 25% of women. However, not all polyps are symptomatic. They more commonly occur in women less than 40 years of age. Less than 5% are associated with neoplasia and almost invariably occur in postmenopausal women. Of those that are symptomatic, the most common manifestation is abnormal uterine bleeding, particularly in postmenopausal women or intermenstrual times of the menstrual cycle. The pathologic hallmarks are thick-walled, centrally located blood vessels, an alteration of the stroma, often with increased fibrosis and collagen deposition, and an irregular glandular architecture. This image shows all three pathologic hallmarks of endometrial polyp. As a result of endometrial sampling by biopsy or curettage, polyps are often removed piecemeal, leading to loss of several useful architectural features, such as central vessels, shown in the red outline, surface lining epithelium, which we don't see in this image, and a connecting stalk, also not present in this image. In general, pathologists need two of the three following features before a diagnosis of endometrial polyp is rendered: thick-walled vessels, alterations of the stroma, as indicated by the blue outline, with increased fibrosis and collagen deposition, and irregular glandular architecture, highlighted with the green arrows. Inflammation of the uterus is a relatively uncommon cause of abnormal uterine bleeding. Acute endometritis is uncommon and limited to bacterial infections that arise after delivery or miscarriage. Retained products of conception are the usual predisposing influence. Removal of the retained products of conception by curettage and antibiotic therapy is followed by remission of the infection. Chronic endometritis occurs in the following settings: in patients with chronic pelvic inflammatory disease, in postpartum or post-abortion patients with retained gestational tissues, women with intrauterine contraceptive devices, tuberculosis, but in about 15% of cases there's no obvious cause. With the exception of tuberculosis, the pathologic hallmarks in chronic endometritis are nonspecific. Scattered plasma cells are present in the endometrial stroma, and the presence of plasma cells is essential to the diagnosis. In addition, lymphoid follicles may be seen, as seen in the lower panel, indicated by the red arrow. Adenomyosis is another common structural cause of abnormal uterine bleeding and is defined as the presence of endometrial tissue within the uterine wall, or myometrium. The arrow points to endometrial glands and stroma that are present in the myometrium. The cause of adenomyosis likely is from downgrowth of endometrial tissue into and between the smooth muscle fascicles of the myometrium. Why this occurs is not known, whether it's due to mechanical or other causes. Similar to endometriosis, the clinical symptoms of adenomyosis include menometrorrhagia, colicky dysmenorrhea, dyspareunia, and pelvic pain. Endometrial hyperplasia is another structural cause of abnormal uterine bleeding and is a bridge to neoplastic proliferations. Endometrial hyperplasia is defined simply as an increased proliferation of endometrial glands relative to the endometrial stroma. Endometrial hyperplasia results in an increased gland-to-stroma ratio when compared with normal proliferative endometrium. Endometrial hyperplasia has malignant potential, and multiple studies have supported the concept of a continuum of proliferative glandular lesions from simple hyperplasia to more complex hyperplasia, the acquisition of cytologic atypia leading to low-grade endometrioid adenocarcinoma. Hyperplasia is associated with prolonged estrogen stimulation of the endometrium. So, multiple conditions associated with hyperplasia result from these conditions causing prolonged unopposed estrogen stimulation, such as obesity, menopause, polycystic ovarian disease, functional granulosa cell tumors of the ovaries, excessive cortical function, as in you learned about adrenocortical hyperplasia, and prolonged administration of estrogenic substances, particularly estrogen replacement therapy. This is a cross-section of uterus cut longitudinally. In hyperplastic endometrium, the endometrial lining is often characterized by abundant white to tan tissue that may have a diffuse, undulating, or polypoid distribution and may protrude into the endometrial cavity. The pathologic hallmarks vary according to the architectural complexity and cytologic atypia. In simple hyperplasia without atypia, there is increased endometrial volume with balanced proliferation between both glands and stroma and the absence of cytologic atypia. In complex hyperplasia without atypia, there's an increased volume of glands compared to stroma. There's glandular crowding with outpouching, papillary infoldings, and back-to-back arrangements. In simple and complex hyperplasia with atypia, the same architectural features of either simple or complex hyperplasia are present, but now associated with nuclear atypia, including loss of axial polarity, large round nuclei with nucleoli, and vesicular chromatin. This is a review slide for comparison as we look at examples of hyperplasia. What the comparative value is what early to mid proliferative endometrium looks like. Notice that in this case the glands to stroma ratio is slightly below 1. That is, there's slightly more stroma than glands. Now we'll compare that in the next few slides with examples of hyperplasia. Note first of all that now the gland to stroma ratio is greater than 1. Most of the tissue in this image is composed of glands. The endometrial glands are crowded and show irregular shapes and cystic dilation. In more complex hyperplasia, now the lesion shows increased architectural complexity with irregular branching glands, infolding of epithelium, and glandular crowding. But there's still not significant cytologic atypia. Finally, in complex hyperplasia with atypia, there's an increase in the glandular to stromal ratio. Again, the same architectural complexity we saw in the previous slide, but now when we look at high power, the cells show eosinophilic cytoplasm and loss of nuclear polarity. So instead of the normal nuclei being at the abluminal or basal aspect of the glands, they are stratified throughout the entire thickness of the epithelium, and you see nuclei present at the luminal surface. They also show nuclear enlargement and round nuclei with nucleoli. The risk of progression or associated endometrial hyperplasia is demonstrated in the next few slides. In simple hyperplasia without atypia, there is an uncommon progression to endometrial carcinoma, 1% or less of cases. Simple hyperplasia with atypia is a very uncommon pattern, but the presence of cytologic atypia confers an increased risk of progression to endometrial carcinoma, approximately 8% of cases. Complex endometrial hyperplasia without atypia shows a similar risk of progression to endometrial cancer, as with simple hyperplasia, with or without atypia. The most significant association with endometrial carcinoma is with complex hyperplasia with atypia. Depending upon the studies, approximately 25% to 50% of women showing complex hyperplasia with atypia on biopsy have endometrial carcinoma synchronously present when hysterectomy is performed shortly after biopsy. Thus, this lesion is managed by hysterectomy, or in young women, a trial of progestin therapy in close clinical follow-up. So, to sum up the causes of abnormal uterine bleeding, where the uterus is the source, we distinguish between functional disorders, or dysfunctional uterine bleeding, most commonly associated with anovulatory cycles due to some disruption of hormonal balance, versus structural disorders including endometrial polyps, endometritis, adenomyosis, and endometrial hyperplasia. Importantly, note that there are benign and malignant tumors, which may also be associated with abnormal uterine bleeding, and endometrial hyperplasia represents a continuum of proliferative changes that can progress to endometrial carcinoma. Thanks